So now we are talking about principles of pharmacokinetics. My conflict of interest declaration, I have just received honoraria from Aspen for teaching. When you give a dose, you expect to get an effect. But this will go through the creation of a certain concentration, and in anesthesia, concentration, the effect is proportional to concentration. So this dose-effect relationship can be separated into two parts. The first one is pharmacokinetics, from dose to concentration. It is what the body does to the drug. The second step, which we shall see later, is the relationship between concentration and effect, and this is called pharmacodynamics. It's what the drug does to the body. There is a sort of gray zone, which is a transfer to the effect side, because obviously this transfer is pharmacokinetics, but you have to estimate the effect, and this is a pharmacodynamic parameter. The different pharmacokinetic steps are, first of all, the absorption, if the drug is not given intravenously, then the distribution from the central compartment to the various organs and tissues, and then the elimination, transformation of the drug by either metabolism or excretion in bile and urine. A very important part of the absorption when a drug is given orally is what's called as the first pass effect. When a drug is given orally, it will undertake a crossing of the liver before entering the systemic blood flow. And during this crossing of the liver, part or the totality of the drug may be metabolized by the liver. And the amount of drug which goes into the systemic blood flow defines the bioavailability of the drug. To see the importance of this first pass effect, you can see here three very well-known drugs, diazepam, midazolam, and propofol. Diazepam has a low clearance. If you give orally 10 milligrams diazepam, you will get 10 milligrams in the systemic blood flow. With midazolam, which has a higher clearance, you can, if you give 10 milligrams orally, you will get about 5 milligrams in the systemic blood flow. But an important point is that the variability of this bioavailability is important, and it depends on the cardiac output. If an anxious patient gets 10 milligram midazolam orally with a high cardiac output due to the anxiety, you can get less than 5 milligrams in the systemic blood flow, whereas a patient on beta blockers will have more. If you give whatever amount of propofol you wish to a patient orally, nothing will appear in the systemic blood flow because of the high clearance. Once the drug is in the systemic blood flow, it will be distributed actively or passively to various tissues. And the penetration of the drug varies with different tissues. A good example is the penetration of antibiotics in the prostatic tissue. If the drug is protein-bound, only the free fraction will be distributed. And there are two main proteins linking the drugs in the plasma. The plasma albumin, which links the acidic drugs such as midazolam or propofol, and the inflammatory protein alpha-1 acid glycoprotein, which links the basic drugs such as fentanyl and its congeners. Another important point is that if the affinity for the metabolic enzyme is superior to that for the binding protein, the drug will be displaced from this protein to the metabolic enzyme, and the binding will not limit the clearance. This is called non-restrictive clearance, and a good example is propofol. The liver is one of the main organs for metabolism and elimination of drugs. Its role is not to inactivate the drug. The liver renders xenobiotics accessible to excretion in urine and bile, so it will render them water-soluble. The liver's role is to eliminate molecules which obviously are not endogenous to the body. It will also, of course, be able to excrete them in the bile, such as, for example, rocuronium. As far as metabolism is concerned, there are several reactions in the liver, several enzymatic enzymes, and some of them hydrolysis, oxidation with the very important P450 cytochrome system, or even reduction, will render the drug water-soluble. They are called phase 1 reactions. The phase 2 reaction will obtain the same result by adding a radical to the drug, mainly conjugation, but it can also be methylation or acetylation. The hepatic clearance is the product of the hepatic blood flow by the extraction coefficient. This extraction coefficient is the ratio between the enzymatic activity, intrinsic clearance, over the sum of the hepatic blood flow and the enzymatic activity, intrinsic clearance. You see that if E is close to 1, the hepatic clearance will be very close to the hepatic blood flow. In this situation, the clearance is flow rate dependent. If E is small, that's low extraction, the intrinsic clearance is small when compared to the hepatic blood flow, and the equation of the extraction coefficient will be close to the ratio between intrinsic clearance and hepatic blood flow. So, in this situation, the hepatic clearance approximates the intrinsic clearance, and it is enzyme dependent, but insensitive to changes in blood flow. One of the main interests of pharmacokinetics in anesthesia is to define the time course of action of a drug. And the first step is to define the evolution of the concentration by pharmacokinetic analysis. The first, if you look at the concentration over time relationship, one of the main way to analyze it is to decompose it into a sum of several exponentials, usually from 1 to 3. And never more than 3, because the far exponentials will not be precise enough for analysis. When you have this equation of the sum of 3 exponential, you can modify it through mathematical formulae to other forms which are more easily understood by clinicians. And one of the main forms is the bucket pharmacokinetic model. In this configuration, there are either 3 volumes and 3 clearances, or 1 volume and the intercompartment and rate constants from and to the peripheral compartment and the elimination constant. You have here the way to go from one expression to the other. This is called compartmental analysis. Those compartmental models are very simple. they are actually have not much to do with reality, because you assume the drug to be instantaneously distributed into the peripheral compartment with a similar concentration everywhere in the compartment, which of course is not true. It is by postulate you say that the drug enters the central compartment and the peripheral compartments are only linked to it through the central one. That is what is called a mammillary model, and the elimination occurs only from the central compartment. And this also obviously is sometimes not true, for example, with remifentanil. But their main advantage is that they work, and they allow to define the time course of action of the drug, at least at the level of complexity adequate for clinical practice. There are other ways to analyze, to do pharmacokinetic analysis. And one of those is the physiological models. Those models are very complex and can be very complex, especially if you have a great amount of data and you have data on the binding. You will model all the different organs with their own parameters, and thus define rather precisely the time course of action of the drug in the body and through the different compartments. It is useful to study pathological states, and as not all the data are available in humans, you can build that kind of models in mammals, and then you extrapolate it to humans by allometric scaling. There is another way to study the main pharmacokinetic parameters, and this is the moment analysis with the theory of the statistical moments, where you will define what is called at the mean resident time, which is the average time which a molecule will remain in the body before being eliminated. And to study this mean resident time, you will calculate what is called the area under the moment curve, which is rather like the usual AUC, but you don't take the concentration as the y-axis parameter, but you take in that parameter the product of the concentration over the time. And thus you can calculate clearance, mean resident time, and the volume of distribution from empirical data. This is the reason why this analysis is sometimes referred to as a model independent, but this is not completely true. How do we build up a PK model? You have to get patients or healthy volunteers, give them the drug, either by bolus dose or infusion, take many blood samples, and specifically at critical phases of your infusion. And then you can do either what is called a two-stage analysis or a population kinetics. Two-stage analysis means that you will analyze separately all the curves of all your patients and define their individual parameters, which you can afterwards pull together to calculate a mean parameter for your population. This has been used a lot to study, for example, elderly versus young patients, or renal failure or liver failure patients as compared to normal ones. But nowadays, all the pharmacokinetic building of a model is going mainly through what is called population kinetics. Population kinetics, in this approach, you will take all the blood samples from all the patients and study them together. This is what is called pooled approach. Then you will build a curve that goes through all those points with less distance between every point and the curve. After that, you will try to see whether you can improve the statistical likelihood of your model by adding significant covariates and weight every point with the covariate that corresponds to the individual patient. And the main covariates are usually weight, age, sex, etc. You will study the influence of the covariate for every parameter, and when you have finished to build up your population model, you can re-estimate the individual parameters by Bayesian adaptation and get the post-hoc values. Some populations, for example, children, are difficult to study with the traditional population kinetics model. You have to have specific model. But this is not anymore completely true, since, for example, Michel Strois and his team with Eleveld have built up models with allometric scaling, and they have been able to build models for propofol and remifentanil, for example, in which you can include children, elderly patients, obese, etc. The validation of a pharmacokinetic model is very important. You will establish the model in your population, and then, of course, it will be okay for those individuals. But you will have then to confront it to real life. And once established, you have to prospectively test your patient in another group of individuals. This has been done, for example, by Jorgen Schüttler with propofol. He has taken 270 patients coming from all the world and research teams who had data. They use the first half of the patient to build up the model, find the significant covariates, and then they have tested their model on the other half of the population. Now we shall see briefly how to apply pharmacokinetics to clinical anesthesia. Of course, when the idea of giving a drug to a patient is to obtain an effect, and if you wish to keep the effect for a certain amount of time in what can be said as a therapeutic zone. You see here that manual infusions will not get a stable concentration in that zone. I have no time today to talk about it, but this is the basis of target-controlled infusion. At induction of anesthesia, there is a delay between the plasma concentration of the drug and the effect. For example, in these works by Scott, which are 40 years old, he gave fentanyl at high doses in order to obtain an EEG changes. And you see here that for the fentanyl, there is a significant delay between the plasma concentration and the modification of an EEG parameter, which is called the spectral edge frequency. And also, once the fentanyl infusion is stopped, the plasma concentration decreases very quickly, but the EEG effect lingers over time. And you see that with alfentanil, those delays are much reduced. And this is due to what is called anti-clockwise hysteresis loop. That's to say, if you give a drug and look at the concentration, you will get a maximum, and then you stop the administration and the concentration will reduce. But as it will take time for your drug to reach the receptors at the effect site, for the same effect, you will have two different concentrations, considering that you are going up or down. And by introduction of a new exponential in your model and collabing this hysteresis loop, you can reach a value where the concentration is the same going up and going down, and this is called the effect site concentration. To obtain this, you can add a new compartment to your model, a fourth compartment, which is called the effect site concentration. As it is the sum of the receptor to the drug, it has no volume. Its volume is epsilon. And so you will define it mainly by the intercompartmental clearance, which will be the product of the volume of the central compartment by a constant transfer rate from V1 to V4, and this is K14. I have no time now, but this K14 is, for historical reason, is called KIO in the papers. Is there a way to control that this calculation of the KIO is not only mathematics out of nowhere? Yes, there is. And in 2000, Charles Minto described a new physiological variable which is independent from any model. If you administer, for example, in an elderly patient, propofol at a low dose, you will see the beats going down and then up again and reaching a nadir. And this, to measure the time of this nadir, this is called the time to peak. And then if you recalculate the KIO linked to this time to peak, for example, in the Marsh model and Schneider's model, you see that the Schneider's model, which is a PKPD model, yields KIO which is very close to that described in this elderly lady, whereas for the Marsh model, the one implemented in the model is completely wrong. And you have to put another one if you want to use this model. Another application of this time to peak effect is the time, for example, for the opioids. You see that two opioids act very quickly, alfentanil and remifentanil, whereas fentanyl and even more sufentanil reach a peak much slowly. And as a consequence, if you want to intubate your patient, you will have to administer the sufentanil or the fentanyl before the hypnotic, and so as to have the maximum effect at the time of intubation, whereas with remifentanil or alfentanil, you can do it at the same time. Of course, time to peak is different from onset time. And you see here, if you want to reach 8 nanograms remifentanil, the bigger dose you give and the shorter the time to reach this concentration. The same for 4 nanogram per mil. And but you will pay this shorter time by a biggest maximum concentration, yielding possibly unwanted effects such as drop in arterial pressure. Once more, instantaneous mixing is an approximation, and the team from Chicago have studied recirculatory models, that's what they call front-end kinetics, to better define the first minutes at induction of anesthesia. A few words on recovery. At the beginning of the 90s, the team from Duke University defined a new pharmacokinetic parameter which is called context-sensitive half-time. And this context-sensitive half-time defines the time for the concentration to be divided by 2 at the end of a constant concentration infusion. But you can see easily if the concentration at which the patient will open their eyes is 1.2 micrograms per mil, you can see easily that if you have been infusing at 6 micrograms per mil, when you give the context-sensitive half-time will be calculated at 3 micrograms per mil, and you are far from recovery. And so a new parameter has been defined by Belay and al., and this is decrement time, and which is a mixed PK/PD parameter, which allows calculation of the recovery time. The context-sensitive half-time main interest is to compare the drugs between themselves. So remember, the main points are: thinking in concentration is very important to understand the drug time course of effect and predict the effects and the interaction. To predict drug concentration over time, you need mathematics, but never forget that pharmacokinetics is primarily proteins, enzymes, liver, kidney, blood, fluids, and cells. And this will help you to analyze your individual patient. If you understand pharmacokinetics, you will be able to understand what happens to your drug, even in patients widely different from the standard population. Well, I thank you very much. Well, most anesthetic drugs, apart from the muscle relaxants, are lipophilic drugs, and so they need to be metabolized by the liver or other organs before being eliminated. So for most of them, they have no active metabolites, and the renal failure per se will have no influence on the pharmacokinetics of those drugs. Of course, this is different for muscle relaxants. But anyway, renal failure may have an influence because the patients with end-stage renal failure have hemodynamic problems. They are very often hypertensive, cardiac, and so forth. So these may have influence on the pharmacokinetic of anesthetic drugs, but not the glomerular filtration rate per se. When the Marsh model was designed and the first deep refuser put in the market at the end of the 19th, there was no KO, and the concept of PK/PD relationship was not completely understood. So just to calculate an effect site concentration, Seneca introduced a KO which was taken from an abstract published by Jürgen Schütter at the EASA meeting, and where the KO was calculated in a non-compartmental way. And this proved to be wrong, actually. And when Thomas Schneider published his paper as a PK/PD model, he found a different KO, which is much more in accordance with time to peak and with the actual time course of action of the drug. So to implement the Marsh model in TCI pumps allowing effect site target, they had to modify the Marsh model. And question number 3. even if the terminal half-life of propofol is longer than that of midazolam, at the end of an infusion, the propofol concentration will drop much more quickly than midazolam, yielding a shorter recovery. Also, the propofol enters the deep compartment, but it is trapped in it, and it will get out of it very slowly, much more slowly than the elimination rate. So in fact, despite the presence of propofol in the body for a long time, it doesn't clinically accumulate.